감사합니다. Good morning. Welcome to community conference here in CHAHPMC Presbyterian Medical Center. Our speaker today is Dr. William Long, orthopedic surgeon here at CHAHPMC. Dr. Long is a pioneer of rope-assisted surgery, having performed the very first procedure of its kind in Los Angeles back in 2008 in Los Angeles. Now, let's welcome Dr. Long.
We call the lecture Smaller Incision, Greater Precision, Computer-Assisted Hip Replacement. I believe that we can put in the hip replacement through the smallest incision anywhere in the world, and we can also put it in more accurately than any other technique, and this has been available here because Dr. Chaw brought us here and purchased the computers that we use. First, we need a little science lesson, the science of human anatomy. This is an image of a hip. Simple science, it's a ball and socket, and the most important part to understand is the white, smooth cartilage that allows it to glide effortlessly with no friction and no pain. Our job is to reproduce a perfect human hip that allows the patient to do everything a normal hip can do. Our goal is to make it so that you can return to all of the activities you could do before the hip became arthritic without any restrictions, and to have it last a lifetime. Of all the operations in orthopedics, we're closer to that with hip replacement than any other operation. The next lesson in science is, what is arthritis? When you lose the cartilage, that white, perfect layer, you see it on one side, there's good cartilage. This is a picture from in surgery. The other side, the cartilage is gone. Most people, if they live long enough, they will get arthritis of the hip. How does the doctor know the correct diagnosis of arthritis? They shouldn't do one thing, they should do three things. And if they don't do all three, you make mistakes. They should listen to you. In orthopedics, they should put hands on you and touch you. And third, they should look at the x-rays. If they only look at the x-ray, you should be concerned and a little afraid, because if all three things tell the doctor the same answer, then they have the right diagnosis. If you only look at one, there could be two problems, there could be other problems, and you can make a mistake. The first thing is, all of your life, people say, put your hands on your hips, and you put them up here. That's not the hip. Patients with arthritis, if you listen to them, most often, they will say they have groin pain, because that's where the hip is. Here, the ball and socket, it's here, it's not up here. Second, if you listen, the patient will tell a story. Most commonly, they'll say, first, I used to love walking. I like to walk on the beach. And I would start getting groin pain when I'm walking on the beach or going upstairs and downstairs. I can't do fun things I used to do. And many times the patient will think, oh, I'm just old. If you continue to listen to the story, then they'll say, now I'm having trouble when I just stand at the sink and try to cook. I can't go grocery shopping. I can't go to the mall. And if the story continues and we listen to it, then you will learn that the patient is trying to rest in their own bed at night, and they move the wrong way, and now they can't even sleep at night. That's how you can diagnose hip arthritis, by just taking medical history and listening.
Walking your dog in high heels wasn't possible a few years ago when 47-year-old Amy Cooper was in excruciating pain.
I could barely walk. I looked like an old lady walking down the street.
3 orthopedic surgeons told Amy she needed back surgery. Being an athlete and avid horse rider went tough on her body, but Amy didn't think it was her spine. Finally, she found Dr. William Long.
Wrong diagnosis. 3 orthopedic specialists told her she needed her spine operated, and she didn't have a spine problem. How could this happen? I believe because they didn't examine her properly. Maybe they were spine specialists and they only checked her spine. You put hands on and you examine a patient and you won't operate on their spine when they have a hip problem. If they had only examined her hip, a round ball in a round socket spins. When it's no longer round, it won't turn. Third, x-rays. And everybody hears, if it's bone on bone, you need surgery. Not true. Many times, the young surgeons, they make mistakes because they walk in the room, they don't talk to you, they don't examine you, and they look at the x-ray and try to make a decision and tell you you need hip replacement. 3 different hips, and all of these had hip replacement. One of them, many would think this is a normal hip because they have a space between the ball and the socket. This patient was in pain, their hip didn't move, and they had a big hole right in this area of the cartilage. They hurt just as much as a patient with bone on bone. Sometimes the x-ray is so bad, the bone is breaking apart. It still doesn't mean you need a hip replacement. If you don't hurt and you're not active and you don't want to be active, you don't need surgery because they see that on an x-ray. You have the power to decide and tell the surgeon if you need hip replacement, because there are 2 reasons to have it, and they're personal. Number 1 is pain. You have so much pain that you say, I want surgery if it will stop the pain. No one can tell you how much you suffer and how much it hurts. You get to tell us. The second reason for surgery is disability, and disability is personal. This firefighter, fire captain, he didn't have pain. He had disability.
Been a captain in the fire department for years, 29 years on the job. And at the same time, I played tackle football for the fire department. I played in the gold medal basketball team. I played in the gold medal softball team. I moved from the outfield to catcher. So I got a desk job. So getting on and off the fire engine was tough. The design was out for me. I don't want to get on one of the scooters. I don't want to do that, but I'd have to say, meet me here in an hour.
The reason he wanted surgery wasn't pain. He wanted to return. After 30 years of being in fire department, he still wanted to work. He didn't want to play catcher. He wanted to play outfield. That was a disability to him. And he wanted to take his daughter to Disneyland. And he couldn't do it. That's personal. Everybody has different dreams and activities, and they decide if they want to have surgery so they can do it again.
I'm kind of just medication free now. I actually ended up losing about 18 pounds since my surgery, which my wife likes. Oh, I'm gonna be able to get a nice, good baseline jump shot, you know. I'm gonna play tennis again. I'm pain free. My back isn't hurting, my hips don't hurt. It's just night and day.
Same man. Next, the next thing you have power over, you can choose the surgeon, because that's a very important choice. That choice can profoundly affect what happens to you, because the surgeon, they can decide who to operate and who not to operate. There are different ways to do the operation, and there are different technologies, and some use one technology, some use another, and the surgeon decides. The wrong choice of implants could have an impact on your future.
Doctors were telling me that I should wait to get the hip operation because so many were failing, and he pretty much said, if you can deal with the pain, don't get it done.
What have you noticed in the last 6 months?
Well, I think just overall his whole attitude changed. He was really depressed before, and not being able to do the things that he could do every day. Being 26 years old and on a cane, and he had no quality of life, and now he's much happier, and he's strong and healthy again the way he should be.
Never did that before.
They told him he was too young. He went to doctors and no one would do his operation. They told him, wait till you're 65 because the parts will wear out. But the doctors that he saw didn't understand that we had better implants.
Places do you think you went?
Too many.
More than 3?
No. More than 20, 25 places.
And you had been without a hip for 3 years?
Almost 4.
And then all this time, when you didn't have a hip, how are you getting around?
In a wheelchair.
And then when you would go to see the doctor and ask what's next, what were you told?
Nothing, that it was too hard, too complicated, that I could die. Just did a walk for the Ronald McDonald's house, a 3-mile walk. I've done this in my 4th year, but this is actually the 1st year that I walked, because the other 3 I did it with my wheelchair.
The doctor told her, too difficult, can't be done. So they left her in the wheelchair. Wrong, she went 25 doctors, and none of them would do it. Also, she's big, and without a computer, they're afraid they're going to put the parts in incorrectly. So it makes a difference where you go. The next choice besides patient selection is surgical approach. There are different ways to get into that socket, and some go in one way and some go in another, but there's one thing that's important. Don't kill the muscles and get in a way that they can heal fast. My mentor in the early 2000s began working on getting into the hip through the smallest incision possible. The reason it didn't become popular is because all the experienced surgeons say if you try to put a hip replacement in an incision so small, you won't be able to see, and you're going to put the parts in incorrectly. But Dr. Dorr was a genius, and at the same time he did this, he brought computers into the operating room for the first time. So suddenly we had the smallest incision and the most accurate placement of the implants that anyone had seen. That's a quarter. That's 25-cent piece. That's real. This is our typical incision. People say they're going through the same incision we use. They call this the same incision as this, but they're not the same. With a computer, you can do it like this. Without a computer, you go in the same direction, but you have to open it wide so you can see. This is how we do it. Muscle here. This is not muscle. Muscle here. We go where there's no muscle. I would never show this if there were blood everywhere, but you look, you maybe don't see more than one drop. Now we're down to bone and there's no bleeding, and we didn't cut muscle. You can see, we can put that implant into the hip through the small incision because we have a computer. It has 2 eyes. It's watching the implant. There's another tracker on the pelvis. It can see the socket and the implant, and it can tell us that even though we don't open the body up, that we're putting it in correctly. So now we're back to the start of the lecture. Smaller incision, greater precision, computer-assisted hip replacement. So this is what we're trying to do. We love to see that we can put that cup in the right direction. The socket must point toward the ball. If you don't point the ball toward the socket, the hip will come out of socket. You put it in the right direction and you prevent hip dislocation. When we began this, that was the #1 cause of having to go back to surgery for failed surgery. #1. Second, if you put it in too deep or too shallow, the muscles are like a fine-tuned guitar. If you stretch them too much, it's a bad note. If they're too relaxed, a bad note. And then there's just right, the perfect note. The depth that you put that cup in changes how the muscles work. If you put it up too high, you make the leg short. That was the #1 cause of orthopedic surgeon getting sued after hip replacement because they leave it in, it's short, and the patient's unhappy. One leg is shorter than the other. With the computer, if we change the length by 1 millimeter, everyone in the room knows it. The computer also helps with one more thing, putting this piece in. If you put it in too high, the leg's too long, and it stretches the muscles. You put it in too low, the leg's too short, and the muscles are weak. So it helps us reestablish putting in that part correctly. It just makes sense. You don't have to be an orthopedic surgeon to understand that's why we use a computer. Why would surgeons not want the computer in the room? Because they thought it would take longer. It does take longer by a few minutes. We chose to add a few minutes to surgery and do it with the computer. For implants, we have implants now that we believe will last even a young person a lifetime. We can't be sure. We can be sure about 15 to 20 years. We don't know what happens after 20 to 30 years. Now, what if you've had surgery with no computer? The message is not that it's not a good operation. This young man is in Cuba, Havana, Cuba. 2 bad hips.
I love it. I love it. Oh my God. Oh, no.
I did his surgery with no computer. Maybe if we checked his leg lengths, maybe one is a little shorter. Maybe one's a little longer. But the message is, if 80% of surgeons aren't using this technology, you don't have to feel that you got a bad operation. You can be an artist, and you can have experience, and you can deliver good surgery without the computer. But if I have a choice, and I do when I'm here, I choose to use computers. Dr. Dorr was my teacher. He's the one that invented that small incision. He also brought that computer to our room, and he taught me how to use it. He also started Operation Walk in 1997 in Havana, Cuba, and in that year, he planted a sapling, a tiny tree. In 2019, his last trip, it was a big, giant shade tree. He did surgery on governors and famous people and the rich, but his philosophy was, I don't operate on people who just have money. I operate on people who need it. He said, I serve those in need. Shaw Hollywood Press supports Operation Walk. We're returning to Cuba October, November this year. Our team, Dr. Chan has been with me, our anesthesiologist. We've had our team that works with us, and they feel the same way. And so we're very grateful that they brought us here. He brought us here because he wanted us to bring this technology to this community. So I thank Dr. Chaw for bringing us. I thank you all for coming. I thank marketing for all the work you did, and administration and my office staff for making this event possible. Thank you very much.
감사합니다.